I have the great honor and the pleasure to introduce one of the most eminent figure in the field of oncology, Ahmed Shesh. Ahmed Shesh is a pioneer, not in breast only. He created a very specific and unique model in نقول ايه patient cancer care. يعني في الحقيقة أنا اتشرفت لما رحت له شفا الأورمان. He is doing a very great job. Ahmed, honored to be with us today. Dr. Ahmed will tackle a very important topic. Dr. Rasha will introduce him.
يا دكتور لبنى، ده شرف ليا وانا يعني سعيد بالدعوه الكريمه وان انا في بين اسرتي واساتذتي كلهم. يعني it's an honor.
طبعا انا مش هتكلم عن دكتور عماد. دكتور عماد ده اصلا احنا وهو دفعه واحده، كليه وقصر عيني ومعهد اورام. يعني he's great speaker and he will introduce us about Erlida.
شكرا لحضرتك يا فندم. صباح الخير على حضراتكم، ومرة تانية بشكر حضراتكم على الحضور، وبشكر Janssen for inviting me for this session. The topic today is one of the hot topics that is arising for management of metastatic hormone-sensitive prostate cancer. And the title of my presentation will be Aplutamide in the metastatic hormone-sensitive prostate cancer, with a direction for securing the future options. So this is my disclosures. And we all know that the prostate cancer journey is actually can start from being of the localized advanced prostate cancer, receiving the definitive therapy. Then we follow our patients with the rising PSA when there is a biochemical recurrence. And we have two options here, where unfortunately there may be a metastasis, and that what we call the metastatic hormone sensitive, or as well that the PSA, there is a rising of the PSA despite the castrate levels of the testosterone, and that will be the non-metastatic. And how we will resume or start again the ADT, and we need to identify what shall we do to expand the part of being hormone sensitive before entering into the part of the castrate resistant. But we need to ask ourselves, what can we actually expect from the ADT alone? And that's actually didn't have this answer till we have a cohort from the Stampede trial, where 917 patients who were de novo M1 prostate cancer from the year of 2005 to 2014 treated by ADT in this, and the median OS, what we can expect is 42 months. So again, this is for the ADT alone. But then we have a plethora of treatment. We have the effect of different trials that included the Latitude, Stampede, Arches, and Titan that combine the duplet therapy, which is the ADT plus those who are of the standard of therapy for deaths, and decreasing the risk of death by 34% to 40% versus the ADT alone. But as well, there is a new era for the triplet therapy of the PIS1 and the Aracins. And that's keeping up into the fact that we need to identify how the evidence is based. So for the ADT plus the docetaxel versus the ADT alone, what we have three trials, the JTIC, the Charted, and the Stampede, that have an accrual over the years from 2004 to till 2013. And simply, it identifies the addition of the docetaxel for at least 6 cycles plus the ADT. And actually, what we have seen from a meta-analysis, that the median OS benefit from the addition of the docetaxel to the ADT will range from 14 to 16 months. That's what we will hope. So plus the 42 months, that what we will increase is to have more of a 14 to 16 months. But then also, in the part of this is to have the novel anti-androgens, and that's again being presented particularly in certain trials, and one of them is the Latitude trial and also a part of the Stampede trial, where addition of the abiraterone versus the ADT alone. And what we can see that the Latitude included those who are being of a high risk criteria, and that's included a very good portion of patients who are Gleason score 8 or more, and having 3 or more bone deposits. And what we can see that in terms of the radiological progression-free survival and the overall survival, the addition of the abiraterone, whether in the Latitude or in the Stampede trial, had actually benefited over the ADT alone. And as well, this is confirmed with the meta-analysis to have that the addition of the abiraterone to the ADT will add more of a 17 months. So moving forward into the novel third generation of the Enza and the second generation of the enzalutamide and the apalutamide, we have the trials of the ARCHES and the ENZAMET, where it included the high volume, the Novo M1, and that was actually as well for the ENZAMET that allowed the concurrent docetaxel. And we will come to this part when trying to differentiate how to move forward. As well, with the addition of the apalutamide to the ADT, we have the Titan trial, which is including as well 1,052 patients, and that accrual from 2015 to 2017. Just a short report about whether you give radiotherapy to the local primary in those who are metastatic hormone sensitive or not. That was a trial which is included in the Stampede trial and in the HORID. And as well, this trial tried to identify whether the radiotherapy would be of a benefit for patients or not. And that's the take-home message that only was those patients who are low burden, those are the ones who will benefit for radiotherapy. So the addition of radiotherapy in the metastatic hormone sensitive is of a matter of debate and still not answered yet. But then what I have showed that there is a plethora of trials and we are having a lot to do and we are in front of our patients. If we are confused, yes, we need to be confused and we need to try to do our best to try to choose what is the best for our patients. So we need to identify again when we see our patients that those trials have defined different. You will see something which is called the high volume. Then you also in other trials seeing the high risk patients. And that's the charted trial where the high volume, which was again of 4 or more bone metastases, including one of them or more outside the vertebral column or the pelvis, or even having the visceral. That's how they define the high volume disease. And the low volume is definitely those who are not of a high volume. But the Latitude trial is of the risk, and that means that they have 2 or more risk features of the following, which is 3 or more bone metastasis, visceral metastasis, or Gleason grade 4. And that means that the high metastatic burden may be equals the high volume as above, and that's what we now have it in the Stampede. But then we need to identify also that we have 2 types of patients. Patients who are de novo metastatic, and that means that they are synchronous first diagnosis with metastasis, and that's typically those patients who didn't receive any kind of therapy for having prostate cancer. But also we can have a group of patients who are relapsed metastatic. Those are the metachronous with the diagnosis of the metastasis only after the local radical therapy. So definitely, and that's not to compare or cross comparison between trials, but we have the trials and we need to identify how to do it. We have the charted, the Stampede, the Latitude, the Stampede where it includes the abiraterone, not the docetaxel, the ENZAMET, and the Titan. What shall we do? First of all, we have a very good hazard ratio that it is confident of around 0.66 between all these trials. That means that there is a risk of reduction of approximately 34% of reduction for the risks. But then you need to identify how both all the trials identified these and the percentage of patients who are being included. So if you look into the disease volume, what you can see that in the disease volume, the high volume, almost in the Titan, is almost like the shorted trial. And as well, this have been shown and compared with the meta-analysis that shown that the patients will benefit from all these treatments. And what we need to know that ADT alone in those patients is not of a value. So ADT is abundant in all types of patients. So how to choose between docetaxel and hormonal therapy? First of all, you need to understand that for the docetaxel, and that's from the Stampede trial, what we have seen that there is no added benefit in terms of the overall survival for patients. So in terms of the failure-free, yes, but not for this. And it comes with the docetaxel that you have higher side effects for those patients. And that means that not all patients will withstand the addition of the docetaxel. And as well, in terms of comparing in the meta-analysis, the androgen antagonist versus the docetaxel, what we can see that can be, again, the overall survival can be done. So here, we have over the docetaxel, that means that the anti-androgen will be of a benefit for those patients. But then you need, again, to stratify your patients, whether they have our metachronous was of low volume, metachronous with high volume, de novo low volume, de novo high volume. And you can see clearly that those who are different on terms of survival, that means that you don't need to intensify much for all patients, and you need to identify the benefit. So if you have this from the stopgap, it is a meta-analysis for the effect of docetaxel on the progression-free survival by volume and timing. What we can see clearly that there is no benefit for the addition of docetaxel in the low-volume metachronous. And that's one piece of information that you need to identify. And this also have been shown not only for the low volume metachronous, but again, the margin of benefit for the low volume synchronous is much less for the addition of the docetaxel. And that's what we have from this meta-analysis. Back to the Titan, and that's when the aplutamide is being compared to the ADT. And here, we need to take in consideration as well the primary endpoints where the dual endpoints was there of the OS and the radiological progression-free survival. And clearly here as well, there is a good proportion of patients who we know that they are difficult to be treated are being included in the trials with the aplutamide. So clearly, the trial met its primary endpoints in terms of the radiological progression-free survival and in terms of the overall survival. And that's very good to subdivide this into patients who are of a high volume or patients who are low volume, because we know the piece of information that docetaxel is not working much in those patients over low volume, whether they are metachronous or asynchronous. And clearly, here the addition of aplutamide plus the ADT without the docetaxel, it's doing much better in terms, and it's working into the high volume and the low volume. But then, is there other options for the low volume? Because maybe aplutamide, again, there's other ADTs or there's other anti-androgens, novel anti-androgens will work with it. That was seen as well with the ARCHES trial that in enzalutamide have the fact that it can work in for the low volume, but again for the low volume in the shorted it's not working, and as well for the piece one with the triplet, and for the aracins for the DARO plus the ADT, that it doesn't matter for the low volume. So now this is a differentiation what we can do for those patients who are for low volume. And as well, we know that they can be de novo or they can be relapsed. And what we can see from the Titan trial, that it is working whether those patients are de novo or they are relapsed. So whether they are metachronous or synchronous. And that's also an additional point of view. What are the other options for this? You can see that for the shorter trial, for the high volume metachronous, it's working, but for the low volume metachronous, not. For the high volume de novo, it's working, but the low volume. And again, this have to part with the addition of these information in hand. However, you can see that others will include that both of the apalutamide and the enzalutamide will work. Digging through others, because we know that the prostate cancer patient will receive treatment and particularly will have to relapse further. So what are the other clinical is time to PSA progression, and that's clearly shown in the apalutamide, and as well the time to initiation to cytotoxic chemotherapy, so you are preventing some adverse event for those patients. Beside this, as well the time to castration, that means that you are prolonging the patient journey and you can enhance upon it. In terms of quality of life, that is definitely what we can see from the addition of the apalutamide. And if you try to compare anti-androgens versus the docetaxel, this piece of information from the Stampede trial, and that's clearly what we see, that the addition of the abiraterone to the ADT can actually maintain the quality of life of patients, despite that the docetaxel will have the decline of the quality of life. And typically, the adverse events more or less similar between the placebo arm and the addition of the apalutamide. So clearly, these PSA response rates is even being observed. You are assuming that you are giving patients in a front that you will have a better response early, but again, what we are confirmed for the PSA response rate, that what we have seen in the apalutamide within the Titan. Then the question comes whether to use the apalutamide or the ENZA, and that's in terms of the deep prostatic specific antigen. That was a real-world evidence that was presented in the ESMO last year in Paris. And what we can see that the deepening of the PSA response is being seen with the apalutamide versus the enzalutamide. And as well, in trying to compare the enzalutamide and the abiraterone, what we can see in comparison that there is a response of the apalutamide versus the enza and the abiraterone. Simply, this is being confirmed as well in different manners. But again, and this is very important piece of information, and you can see whether you consider that the triplet would be more effective than the duplet, and what we can see that clearly all of them have deepening and can respond well for these treatment, even we don't need to have the triplet in all cases. So not only that being metastatic hormone sensitive, but also to have this further treatments. How do we select best sequence after progression to apalutamide? Definitely, here we have other anti-androgens and we have chemotherapy that is still there. And that was seen in terms of the intent to population. And clearly, the apalutamide have delayed the progression-free survival too. And that means that it does not affect the treatment outcomes afterwards for patients. And as well for these is being those who are receiving either hormonal group or those who had received chemotherapy, that same group. And that means that it is working in both of them. And actually, another piece of information that, yes, coming from the spartan, from the non-metastatic hormone sensitive, but clearly what you can see that the addition of the options beyond the apalutamide, whether you give the docetaxel or the enzalutamide, will be even in favor of having the apalutamide as a priority or first to choice for measure. So my take-home message, that apalutamide significantly prolonged the OS and the radiological progression-free survival in patients with the metastatic hormone-sensitive prostate cancer. Apalutamide is active regardless of the volume of disease and regardless whether it is a de novo or metachronous relapse, presence or absence of visceral metastasis. Apalutamide also improved very clinically relevant secondary endpoints like the time to progression or the PSA failure, and those which we know in when we are treating patients. And definitely apalutamide is well tolerated and has no negative impact on the quality of life. Beside this, apalutamide gives the option that you have further therapies to give. So if we ask ourselves what we can do for our patients in 2023, what for the majority of patients, definitely, and this is again, I have to confirm that ADT alone is not the option to give. For those patients with ADT and docetaxel, I guess again now we have better options, whether for the doublet therapy beyond the ADT plus the docetaxel to give for them, that the ADT abiraterone or ADT enzalutamide or ADT plutamide is yes active for all patients. And again for the triplet, I guess that we have a portion of patients who are low volume, whether they are metachronous or synchronous, they may not be benefiting from the triplet therapy. But again, it's very important that we see that the treatment of advanced prostate cancer, that you need to give now and you need to look further what shall you give for your patients. And again, apalutamide definitely saves options for the future. And thank you so much for your time and listening.
Thank you so much, Dr. Ahmed, for this elegant, comprehensive presentation. طبعا يعني ابروتامايد احنا جربناه كتير وفعلا يعني في الريل لايف we have no side effects، مفيش اي، والريسبونس ريت بتاعه فعلا فوق 90% في اول شهر زي ما حضرتك قلت. وفكره السيكونسنج طبعا دي فكره طبعا يعني قويه. في اي حد حابب يسال اي حاجه؟ any questions؟ طب كنت عايزه اسال بالنسبه للانفستيجيشن اللي بتعملها في البيزما سكان، رايك مكانها فين في وسط
it's a good question for
زي دوت ازاي يعني؟
it's a good question for and the question of Dr. Rasha is identifying the plasma scan for how to put it in the context. I guess that it's very important at term when we have patients who are having local therapy or those who are de novo, that very important. However, again, all the trials didn't put the plasma as part of their criteria to define whether high volume or low volume. So plasma, where we go, I put it, I guess, that for those patients who are at a very unique, that to have a very low volume, that you can still re-challenge with local radiotherapy for them. That's based on the trials from the small portion of the STAMPEDE and the HORAD. That means that the addition of the radiotherapy can be of an effect for them. So that's why, again, if you are following your patients and you do the treatment, I guess those patients, we do the plasma to see if there is a further local therapy for them. However, for the majority, the definitions of the high volume and the high risk doesn't require the plasma for those patients. I hope that this answers your question.
رايك نعمله مثلا فولو اب في الميتاستاتيك؟
If there is a rise or a doubling of a PSA.
follow up just
No, but if the patient is already had received definitive, then, but for metastatic, no added value for the plasma in the metastatic.
في overall survival هل في studies
90%
response rate في
الريسبونس ريت yes yeah. في مصر لا في مصر لا بس however from the clinical practice what I can see that definitely the response to the PSA response is very seen with the ERLEADA with where it can be seen as well with the Zytiga as well. So and definitely with the enzalutamide. So yes, it's good and to correlate this with response, but this is very important to see it. And I guess that yes, from real life data, we can have this. I guess يعني عند حضرتك برضو يا دكتورة رشا في الشرطة في large portion of patients, and definitely identifying the rate of decline of PSA is very important.
اوكي ماشي. طب في اي حد عايز any questions او اي حاجه؟ تمام. اوكي. Thank you Janssen for this opportunity, for this symposium, and